Hi everyone, I'm Dr. Deed Harrison. I'm president of CBP Seminars and Technique, and I'm also president of CBP, or Chiropractic BioPhysics nonprofit, our spinal research foundation. We're located here in Eagle, Idaho. I'm at the CBP Doctor Institute and the Ideal Spine Health Center. Personally, I've published about 100 and some odd scientific research reports. However, collectively, the CBP research team has published well over 150 peer-reviewed research projects. CBP nonprofit sponsors and supports spine research, conservative care, rehabilitation, and biomechanics research. And what we found out is many times doctors and patients out there, they're not aware of the studies that we've put out. And so what we've decided to do over the last several months is we're going through each one of our research publications in a pointed fashion. So without further ado, we're going to get to this week's research presentation. This is our video number 23. And if you've been following these, you know that we've been discussing the lumbar lordosis in health and disease and treatment outcomes. We are going to go through another randomized clinical trial that supports or validates the idea of structural rehabilitation of the shape of the lumbar lordosis to improve back pain and disability. Now, this particular project, it was not sponsored by CBP nonprofit per se, and I was not an author on it. However, my colleagues at the Cairo University over in Cairo, Egypt, they've done some great projects looking independently at some of the work that CBP researchers, including myself, have done. And so what this is an independent look at lumbar extension traction using a supine method as designed by myself back in the early 2000s, actually in the late 1990s, but first tested in the year 2002. These authors revisit this, look at a randomized trial for this lumbar extension traction combined with standard PT to see, does this A, improve the lumbar lordosis, and B, does this improve chronic low back pain? However, first, I want to set the stage by going through an introductory project to show you that the lumbar lordosis does indeed influence people's back pain intensity. Okay, so in past days, we didn't have good projects that really validated or confirmed what it was that clinicians suspected that was going on with chronic low back pain in terms of loss of the lumbar curve. However, starting in about the mid-1990s on up, there's been some very good research projects that have come out. In particular, this one, 2001, out of the Journal of Orthopedic Science. Now, this project was exciting at the time because it's the first project to have done what it is I'm going to explain to you. Okay, they took a large group of subjects with chronic low back pain. Of course, that had been done before. That's not the unique part of this project. So we have 253 no pain subjects matched to 236 chronic low back pain subjects. These subjects are between the 5th and 8th decade of life, or 50 to 85 years of age. They're matching the two groups, no pain and back pain, for age, weight, height, sex, and they're going to look at what's called chronic mechanical low back pain using the visual analog scale. Obviously, the no pain group is not matched for pain intensity to the chronic back pain group. Importantly, exclude fractures, spondylolisthesis, major degenerative problems in the low back, and prior low back or hip surgeries. Looking at upright lumbar x-rays for the lateral lumbar curve using the L1 to S1 four-line Cobb angle. There's a reason that I'm showing this report. You'll see it ties into the paper that we're going to go through that supports lumbar extension traction. The authors use a similar method to this, the L1 to S1 four-line Cobb angle. Okay? Findings in this particular study. Okay? Well, first I should show the measurement. Here's what was done in this particular project, looking at the L1 to S1 Cobb angle, but in this case, this is the two-line angle. The authors used the four-line Cobb angle. Findings: there was no correlation in each of the two groups with sex and lumbar curve, age and lumbar curve, and lordosis. This is important, okay? Many times people believe that the age of the subject, if you have a group that spans from 50 to 85 years of age, many times authors say, well, you can't look at these subjects in different decades of life because it is an age-related phenomenon that we have loss of the lumbar curve. Well, in fact, this study shows that's not true. There's no correlation. Also, studies say the gender of the person, are you a male or a female, that's going to dictate the magnitude of your lumbar curve. What these authors found was the lumbar curve magnitude was not driven by gender. Gender had no effect. Why would a man and a woman have a different lumbar curve? We both walk upright, perpendicular to the Earth's surface, parallel to the force of gravity. Totally ridiculous to suggest that men and women are going to have totally different lumbar curves. It doesn't work that way. We are both human beings. Right? Now, the pelvic inlet, the pelvic shape itself in 3 dimensions is obviously different in a female as compared to a male due to childbirth and childbearing. However, that does not mean the lumbar curve is different. It's not. Okay, so important finding. Chronic low back pain was associated with a strong statistical reduction in lumbar curve. That's what this study found in 2001. That's not the most unique finding in this paper. That had been found earlier. Here's the unique part. As far as I can tell, this is the first project to look at pain intensity correlated linear with loss of the lumbar lordosis. They found an inverse correlation between visual analog pain intensity and loss of the lumbar curve. P equals 0.025. Okay, so in other words, the more reduced your lumbar curve is, the straighter it becomes, the higher your pain scale on a visual analog scale. So a VAS, a 10 centimeter scale. Now this is important. This was the unique part of this project. So what we see is the majority of the high quality literature, okay, there's always exceptions to the rule. So listen to the way I say this. The majority of the high quality literature has found an association or correlation between chronic back pain and loss of the lumbar curve. And in fact, this project is the first one to say there is a linear correlation between the amount of reduction of your lumbar lordotic curve and chronic back pain intensity. Very important. So that brings us to this week's research project. It should say number 23 at the top. My apologies, a little bit of a typo. This comes from the Journal of Back, Musculoskeletal, and Rehabilitation. This was in 2013. It's volume 26, page 213 through 220 by my colleagues, Professor Aliyah Mohammed Diab and Professor Ibrahim Mustafa. These are from the Basic Science Department, Faculty of Physical Therapy, Cairo University in Cairo, Egypt. They're a brilliant team there, and they do fantastic work. So this is one of their trials. 80 patients with chronic mechanical low back pain. Exclude important things like major degenerative disc diseases, exclude spondylolisthesis, and exclude scoliosis, exclude metabolic disorders like diabetes, exclude previous surgeries, etc. So we've got 80 chronic mechanical low back pain subjects. They're matched, and we randomly assign them. I say we, I'm including myself in the project, but that's just how I talk. We randomly assign them to one of 2 groups, a control group that gets IR stretches and lumbar exercises, and then we have a group that gets that same thing plus supine extension traction. Now both groups are going to be treated at Cairo University in their PT department, their outpatient clinic. They're going to be seen 3 times a week for 10 weeks, 30 visits. So both groups get 30 visits 3 times a week for 10 weeks. Both groups get IR stretches and exercises for the low back. Only the treatment group gets lumbar extension traction to rehabilitate the magnitude of the lumbar curve. Now, inclusion criteria, lumbar curves less than 35 degrees. Okay? Also, hypokyphotic thoracic spines. Subjects had to have a mild hypokyphosis. Okay? Now, outcome measures. Back pain rating scale using an NRS, a simple numerical rating scale from 0 to 10, and then the Oswestry Disability Index to look at back pain disability or limitations of activities of daily living. That's what the Oswestry Index does. Okay, X-ray outcomes, lumbar curve, L1 to S1 4-line Cobb angle, thoracic kyphosis using T5 down to T12, sacral slope meaning S1 to horizontal, and then the C7 plumb line was looked at. The C7 plumb line, this accidentally shows the C2 plumb line, should be C7 drawn down to the S1 posterior superior body corner. So we're looking at how far C7 is either in front or behind S1. It's a measurement of sagittal plane deformity or imbalance. Okay, now importantly, we're going to stop care after 30 visits and then follow them for 6 months. Here's our flow chart for the subjects. Always, you got to realize a randomized trial is a convenient sample. It's not a random sample of everybody out there with chronic back pain because some of these subjects don't fit the inclusion criteria. So you start with a group that you think fits your inclusion criteria. You go through an examination with them. You find out some of them don't, so they are out of the project. Or some of the subjects that you do want to include, they don't want to participate in the trial, so they're out as well. So you start with 130, and we're left with 80 subjects randomly assigned to one of the two groups. Okay, so lost to follow-up, 6 people here in the traction group, 3 people here in the control group. So at 10 weeks, 30 visits later, we have 34 out of 40 and 37 out of 40. Now, for a power analysis, this was done prior to the trial. A power analysis indicated the need for 27 subjects. So as long as we're above the 27 subject mark, we're happy to do statistics on this group. We're above this. So then 34 of them make it to the 30 visit treatment evaluation, and then 6-month follow-up, you lose 2 more for various reasons. Now we have 32 of the subjects remaining, meaning we have 80%. And here we have 35 of them remaining, just a little bit more, but both groups are above the 27 mark. Okay, so here's our demographics comparing the two groups. Always you want to look at, are my groups matched for appropriate variables? And you can quickly look through this and you can see that the subjects are primarily matched for all the important variables. There's no overt differences in the major things that we're trying to look for here, okay? However, there is something that is interesting here. You know, it is the medication use. So here's the traction group, their medication usage, and then here's the control group. You can see a clinically significant improvement, maybe not statistically significant in the two groups, where the traction group is actually using less medication over time compared to the control group. Okay, so just to review, the lumbar traction, this is a modification of a design that I designed in 1996, by the way. Actually, the first one I designed was 1995. So the subject lies supine. We're going to load them P to A with a transverse load, a strap, at the area of maximum loss of the lumbar curve. We either pull straight up vertical or we tilt anywhere from anywhere from 5, 10, 15, 20, 25 degrees towards the feet. Okay, that's dictated by the shape of their lumbar curve and the maximum segmental loss of their lumbar curve, what their pelvic tilt is like, etc. We're going to tie down the upper thighs. That way we can force the pelvis to flex under this P to A or transverse load. Then we have to tie down the low to mid thoracic spine with another strap. Originally, we didn't do that in some of our earlier projects, and what we noted, we didn't report this, but we noted clinically, looking at those radiographs later, those subjects started to get a little flattening of their thoracic kyphosis. So clinically, we decided, hey, you know what, we need to prevent that in the subjects that either have a normal thoracic curve or a reduction of their thoracic curve. We need to put a constraining strap around the mid to low rib cage so we prevent the thoracic curve from extending while we're under this P to A lumbar load. And we'll see what this strap actually does. So great addition, testing one of my earlier ideas and seeing if it actually works. It's kind of cool to see other groups testing what it is that I've proposed over the years. I believe I'm right, but you don't know until somebody actually designs a study to test your hypothesis. Okay, so here's the original method that I did. You can see that several years earlier, I had this same idea, and of course, my colleagues at Cairo University were aware of that. Okay, so then back to this. Our outcomes. Our outcomes, very important. Look, the lumbar curve, the study group, 14 degrees. The control group, 14 degrees. I'm rounding up. After the 10 weeks or 30 visits, The study group getting the traction goes up to 20 degrees. Okay, that's roughly a 6-degree change. Look at the control group. You've got 1.5 degrees. That's not statistically significantly different there. That right there is really within the standard error of measurement. However, the two groups are statistically different at follow-up. We now see the traction has done something to the study group. Now look at the thoracic curve, 31 and 30. Now the ideal value for thoracic curve, T5 to T12, is difficult to find in the literature. It should be somewhere in the mid-30s, sometimes as high as the mid-40s. Okay, classically, CBP uses T3 to T10. These authors did not report T3, likely because they couldn't see it on the x-ray. It's very difficult. Okay, so look, the study group goes to 34 degrees, meaning that the traction actually increased the curve by a few degrees. The control group stays the same. There is now a statistically significant difference between the groups, meaning the traction strap around the mid to lower thoracic curve did what it was designed to do. Happy day for Dr. Deed. I look at this and I go, man, sometimes I have a couple good ideas every now and then, right? You could say, well, Deed, every now and then a blind squirrel finds a nut too. Well, that's because a squirrel can smell, by the way. Back to this. So it's good to see this, that traction has actually done what it's supposed to do. That's traction strap. Even though we're pulling on the lumbar curve, we've increased the thoracic curve a few degrees too. Great. Now look at the sacral slope. Sacral slope, 23.5, 24. Those are two groups are matched. 25 to 24, there's a mild difference now between the groups. Now the traction did not increase the sacral base angle as much as we've reported previously, likely because if you read the project, they didn't really pull in the distal lumbar spine in this population. They're pulling more in the mid and the upper lumbar spine, so you'll note that they didn't get a strong increase in the sacral base angle, but it is a statistically significant difference. Here's the important part, the pain. And by important part, I mean these are patient-relevant outcomes. Patients don't really care about their lumbar curve. They don't know enough about it. What a patient cares about is, my back hurts, it's chronic, and I have disability, I can't do the following things. That's a patient-relevant outcome. So let's look at this. 6 out of 10, that's moderate chronic low back pain, 5.5 out of 10. Down to a 3.2, down to a 3.5. Both groups feel good. Both groups feel good. They're both about, 45% improved roughly. So 45% improved in both groups. No statistically significant differences. Both groups feel better. The disability, 32.4 on the oswestry down to 21.8. This group, 31 down to 23, no statistically significant differences between the groups. Now that's at the 10-week follow-up. That's good, both groups feel good. They're about 40 to 45% better in back pain, and they're almost a third better on the oswestry disability index. Stop care, let's see what happens. The theory is, when we improve the lumbar lordotic curvature, we should see continued improvement or stabilization of the pain improvement in patients. However, we need to test that. Okay, so the 6-month follow-up is really important. Both groups are about the same in their pain and disability at the end of treatment. Let's see what happens 6 months later. Lumbar curve, study group versus the control. Most of the correction was stable. Okay, most of the correction, they lost a little bit, just over a degree. Okay, however, there's still differences between the groups. Thoracic curve, 34 to 30. There's a difference. So it was a stable correction in the thoracic curve. Sacral base angle, 25 to 24. It shows a statistically significant difference, but I'm not really excited about a 1 degree difference, right? It depends on the measurement, etc., and the reliability coefficients in there. It shows statistically significant, but let's be realistic, it's pretty close between the two groups. Pain. This is the exciting part from a clinician's point of view. We see now that there's statistically significant differences between back pain intensity between the two groups. At 6 months, the control group is slowly starting to ramp back up towards their pre-study values, to where now there's a statistically significant difference. The oswestry, look at this, 23.8 to 27. The control group starting to get more disability again. Okay, so we look at this, we go, wow, we start to see one of the first projects to show disability may very well be influenced by the lumbar lordotic curvature over time. Now, you will note that both groups still have back pain. Why? Well, that's because both groups still have a reduction of their lumbar curve. This is the problem with the randomized trial. These subjects didn't get taken all the way up to what we'd call normative data. The lumbar curve should be, when we look at L1 to L5, it should be ideally 40 degrees, but it should have a minimum of 35 for most adult subjects. These subjects are only 50% of that or less. They're below 20 degrees. The sacral base should also have a 40-degree sacral base angle. Look at these subjects' sacral base. It's 25 and 24. They're still in the category of chronic back pain. So that's why they still hurt. You know, that's my perspective on this. Of course, another randomized trial needs to be done on taking these subjects and following them further. Now, let's do a second corrective care program of care. Let's get their lumbar curves closer to 40, and then let's see what happens to those groups. These are future projects, but right now you got to go, whoa, this is really cool. We've designed a project to look at, can we change the lumbar curve? Answer, yes. By the way, we already knew that. Previous projects that we did showed that. But the important part is, does it improve back pain faster than or better than typical PT care? Typical PT meaning stretching, some simple exercise, and some infrared. And the answer is, yeah, we found statistically significant differences, okay? So this is the exciting part of this project. So the summary is as follows. Lumbar extension traction, supine. In addition to stretching exercises, infrared, radiation, have a positive impact on the following things. Lumbar curve, pain intensity, disability, and whole spine sagittal balance, meaning the thoracic curve as well. Now, even though we had to word it lumbar traction with the PT, what we found in the PT only group, it didn't happen. So we know lumbar traction does something. It is important, okay? Lumbar traction has a positive effect. Follow-up measurements revealed stable improvement in all measured variables at 6 months. These observed effects should be of value to clinicians and health professionals and patients out there with chronic back pain involved in the treatment of lumbar disorders. In other words, if you've got chronic low back pain, don't take, oh, you got to live with it for the rest of your life as the answer. There are things that can be done. Just because one doctor or one healthcare provider can't help you doesn't mean there's no help. People only know what they're trained in, their personal views, their biases. So what you've got to do is, if you've got loss of your lumbar curve and you're listening to this out there, there's not a million things that are going to improve your lumbar curve. There's only a couple of them. Extension lumbar traction, as we've shown, is the most effective non-surgical method to change the shape of the lumbar curve. And it's not an opinion, it's a fact, okay? You're going to see next week, we're going to do another randomized trial. So there's 3 randomized trials on this procedure and 1 non-randomized trial and a host of case studies. That's enough for me. It should be enough for you. Now, the only group or organization that doesn't buy into this, it's certain types of managed care organizations. Now, I'm not going to name them, but these people, what they do is they go, oh, your chiropractor or your PT's overutilizing treatment. You only need 10 to 12 visits and your back pain should be totally solved. I mean, come on, what a bunch of nonsense. I can't really even say what I want to say on camera because this is going to go out to the public. These people, they get paid to tell you to stop care. They get more money, okay? Certain individuals may or may not have proper ethics in healthcare. You got to realize companies out there, they're in business to make money. And what they will do is they can deny care, you know, that affects you and affects your ability to get the proper care, and then you think it's the doctor that's overutilizing. You think it's the doctor that's outside the standard of care. You think it's the doctor that's unethical for trying to correct your lumbar curve. Well, I'm here to tell you, I think it's the other way around. I think people that are cutting claims in legitimate cases when there's loss of the lumbar curve and there's chronic back pain and disability, I think if they don't give you enough time to correct the lumbar curve, I personally think that that's unethical. That's my personal viewpoint. I get to say it. I've seen it in my career. This is why personally I tend to do more of a cash practice with patients. I don't want to deal with the managed care organization. I don't want to deal with somebody on the phone that may not have the same training as me telling me what I should do. I can tell you right now that I've got way more experience than somebody on the phone does when I'm talking to them. And that's why my staff and my wife, they don't let me talk on the phone to people because I have no problem with telling them. Anyway, that's a side story. Back to this. Hopefully you've enjoyed this week's clinical trial and this week's CBP nonprofit research report. In all seriousness, if you're a patient out there and you've got chronic back pain and disability, there is a very good likelihood that it's related to the lumbar curvature. You've got to seek out treatment from a CBP-trained chiropractor and see if they can help you. There may, in fact, be an easy solution to what you have going on, but you have to put in the work. It's a team effort. No doctor can fix you. You've got to put in the work and you've got to do it, but you got to have a good coach that knows what in the hell they're doing. So please consider the message at the end of this. Also, if you're a chiropractor or a doctor out there, please consider supporting CBP Technique, CBP Seminars, and CBP Nonprofit. Listen to the research message at the end of this. Thank you for your time and attention. I'm Dr. Deed Harrison again. Until next time, have a great week. If you like this information, if you're a patient, you need to go to a chiropractic biophysics trained chiropractor. You can find us all over the United States, Canada, and international locations. Go to www.cbppatient.com. and look up CBP providers in your area. It's an easy-to-use, user-friendly site. Search for, at first, a general or advanced trained CBP chiropractor. If you can't find one of those, then find somebody that's at least on the directory and has taken our courses and that does the work. Okay? So let's go to a CBP-trained chiropractor, www.cbppatient.com. If you're a chiropractor and you're interested in this, either learning more about it or maybe it's brand new to you and this particular video research project intrigues you, come to our website for doctors. Go to idealspine.com. We've got a lot of things there for you. We've got training, we've got conferences, we've got products. Love to have you on board and become one of the CBP doctor family providers, right? We need your help. There's patients out there that need you. And if you don't get trained in this work, then you're not going to be able to provide them the type of service that we think you should be providing them from a corrective care point of view. Also, lastly, anybody out there, we also need your help to continue to do research investigations like this, right? These are time and dollar consuming projects. If you will, go to our website directly and sponsor and support Chiropractic Biophysics Nonprofit. Make a donation of any amount to us. Also, you can do it indirectly on Amazon Smile. Just select Chiropractic Biophysics as your nonprofit foundation, and when you purchase through Amazon Smile and Amazon, CBP Nonprofit will get 0.5% of all your purchases, which is a big deal. It adds.